Hi, everyone. I'm here today with Dr. Barett Andreasen of Radiodontics. I think everybody should be familiar with you because of your beautiful posters that you have in all the groups regarding identifying anatomical landmarks. We have it in our group as well. But Dr. Andreasen is a KOL for Prexion, who's a sponsor of our group. And I asked them a few months ago to maybe can give us a crash course on CBCTs and what the imaging is all about. This is we're going to start from basics, and hopefully we can add on to it in the future lectures that he has. But I thought it would be very important for all of us to get to understand how CBCT imaging works, and look for things that may be important. And Dr. Andreasen, you also have a service, right? That people can send their images to you to read, correct?
Yes, I do. So I have my own company. It's called Radiodontics. So if you go onto our website, radiodontics.com, we have a service where we provide second opinions and we do CBCT reports, also reports for panoramics as well. And we work with doctors from across the country. So if anyone has any questions on their radiographs, feel free to send them to us. We're more than happy to work with whoever has questions for us.
Yeah, I've always I do use a service, not Radiodontics, because I've been using her for many years, and I've always I was, these are very complex images. And I always thought, how come the physicians send it to a radiologist to read these CAT scans, but we just snap this CBCT and then we'll just place an implant without looking at everything else. So I feel like this is a service we're doing for our members in the group, and hopefully we can add on to it and maybe even make people think that, hey, do use a service to read these images because you can find abnormalities, correct?
Oh, of course. There's lots of different incidental findings that you'll see on a CBCT, but my hope today is that we cover a lot of the basics so that you don't have any fear about going through a scan, right? Getting into this 3D imaging world, it's a brand new experience for a lot of people. And so there's a lot to learn, but it's actually much simpler to learn than our traditional 2D x-rays that we use in dentistry. And we'll look at a bunch of cases of why that is and how we can address some of these issues. And at the end of it, I think you'll be pleasantly surprised with how easy it is to go through a CBCT. And then, yeah, later on, we can talk about all the fun incidental findings and pathology cases, because those are always the fun ones, right?
Great, great. Go ahead and start if you want to share your screen and show us your lecture. We really appreciate you being here today.
Of course, more than happy. All right. So this is a crash course in CBCT interpretation. And like Bob was saying, my name is Dr. Barett Andreasen. I am an oral and maxillofacial radiologist. So what that means is I am a dentist. I'm fully trained and licensed as a dentist, but I just spend all my day looking at x-rays, primarily CBCTs. And it's a really fun job. I really enjoy what I do. It gives me a lot of opportunity to work with doctors and to see fun and complex cases, and of course to help out patients in whatever way that I can. But before we really get started into the lecture, just wanted to jump in and thank Prexion. Prexion is a CBCT manufacturing company. They are an awesome company to work with. I work very closely with a lot of their sales reps doing these kind of educational courses. They're really, really excellent people. So if you have any questions about purchasing a CBCT, want to get in contact with them, I believe Bob will be giving out their information. They're a sponsor of the group. Very excellent company to work with. All right, so the big question that we're going to address today is why CBCT? Why is there this trend in dentistry towards this 3D imaging? Now, we for decades have been using 2D imaging, right? Our panoramics we love and hold dear, and it's really been a fantastic technology for us for quite some time. But with 2D imaging, there's some limitations that we run into. So with 2D imaging, we have all kinds of superimpositions, artifacts, distortions, but we mainly just been dealing with these things because we really haven't had any alternatives to doing so. So maybe for this case, we have here a patient with some pretty big issues with their dentition, right? They're edentulous on the maxilla, they have grossly decayed teeth on the mandible, and really our treatment plan for this patient would just be complete maxillary denture, complete mandibular denture, maybe throw in some implants here or there, depending on the amount of bone that's available. But really, this is all that we get from our 2D imaging. There's really a limitation to our treatment plans when we're just limiting to ourselves to our 2D imaging. There's something on this panoramic that's a really critical finding, and I can guarantee that 99 or 100% of us are missing this critical finding right now. The thing that I want to address today is the limitations of our 2D imaging and how 3D imaging addresses those limitations. And it gives us so much more information than what we've had in the past. So we'll come back to this image later on in the lecture at the very end, and we'll see at that point how CBCT findings can really change a treatment plan for patients like this. So now, if I had to guess why the majority of dentists were getting into CBCTs, I would say that that's because of implants, right? Implants are fun. They're very familiar to us. You know, we're doing restorative dentistry. We're providing a great service to our patients. And so implants, that's kind of like the one reason why most people get into CBCTs. Now, that's not the complete story with CBCTs. CBCTs, they are such a big part of dentistry nowadays. Maybe at the very beginning of CBCTs when they were first introduced, maybe they were just very limited to implants because of the image quality, because of the software and hardware limitations. But nowadays, with all the advancements, with all of the improvements, there's really almost no part of dentistry that can't benefit from CBCT technology. Even if you're just a general dentist doing basic crowns and basic fillings, the diagnostics that CBCT provides is a huge benefit to your office, and you'll see that in just a few minutes. So diving in a little bit more into the more common reasons why people are doing CBCT. So implants and endodontics, let's talk about those specifically. So if a patient comes into your office and they're looking for an implant, this is traditionally what you would do, right? You have your panoramic that you would take. You have a good image of your edentulous site. You might be able to see a good amount of bone height. You see the width of the area. Most times you'll be able to trace the mandibular canal, but that's pretty much all we're getting out of the image, right? There's not much depth to these images that can give us further insight into how to treatment plan these cases. So with 2D imaging, this is what we're limited to. We don't get any depth of the bone, no width. We have distortion, we have magnifications. And so our implant cases, they're not always 100% certain when we go into them if we don't have some kind of 3D imaging. And so as we delve deeper into these cases, what I want to do is I want to look at some examples as to why CBCT plays such a big role in implants. So if we were to take this mandible and we were to slice it like we were slicing a loaf of bread, realistically, any one of these cross sections could represent that mandible in the panoramic. We can have lingual undercuts, we can have very narrow bone in areas, we can have buccal undercuts. The mandibular canal can realistically be anywhere within that mandible, buccally or lingually, and on a 2D image, we wouldn't be able to see any of that. But on our 3D images, it's very clear, right? We know exactly what we're getting as we get into these implant sites. So this is what we really want to see when we pull up a CBCT of a edentulous site. We want to see good bone height. We want to see good bone width. And the great thing about CBCT is that there's no distortion. There's no magnification. What you see is what you get. So I pull up the scan and I'm planning out an implant case. I measure 14 millimeters from the alveolar crest to the mandibular canal, and I have exactly 14 millimeters when I go in to do the actual treatment. On a panoramic or a PA, you're going to vary wildly on your measurements just because of the inherent limitations of your 2D imaging. Tracing out the mandibular canal, it's as simple as pressing a button nowadays. You literally just line up the canal, just click, 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 click and drag along the whole entire canal. And it's a very simple process. And with CBCT imaging, you get exactly what you need for your whole entire treatment plan with these implants. So it's a very simple process, and just uh, the simple fact that you're getting so much information for these cases plays a huge role into the success of your implant treatments. So now regarding CBCTs and implants, the American Academy of Oral and Maxillofacial Radiologists, they put out a position paper. And in here, they made a number of recommendations. We're going to cover just the most important ones. So the first recommendation that they made is that any potential implant site should include some kind of cross-sectional imaging. And you'll notice that's not potentially complicated implant sites. That's not posterior maxillary or posterior mandibular implant sites. It's any potential implant site should have some kind of cross-sectional imaging, and CBCT is the best choice to do that. Now, the reason why the AAOMR made these recommendations is because when you go through the literature, you'll find that the long-term success of an implant is directly related to being able to place the implant optimally and then also to avoid surgical complications. And this is what CBCT is able to do for you. When you have the information that CBCT provides, that anatomy of the mandible, the bone width, the bone height, everything in place, it's much easier to place your implant optimally. And of course, we always want to avoid those surgical complications, which CBCTs are able to help out with. So let's take a look at some of these complications that might arise without a CBCT. So in this first case on the left, we have a very nice mandible. And the thing that we're looking at, the feature that we're looking at right now is the bone density. On this slice, we can see many trabeculations. We can see very dense bone in this area. And that bone density is very critical to the success of our implant. If you compare this to the other image, to the right image, you'll see that it's very radiolucent. There's not much bone present within this mandible. And that's a problem because in some cases, what can happen is that implant just has no bone to support it. And this is what I would call a very bad day, right? You don't want an implant falling down into the inferior half of the mandible on a Friday afternoon when all the oral surgery offices are closed and everyone wants to go home, right? This is a complication that can easily be avoided because you're able to clearly evaluate the bone density on your CBCT scans. Anatomy is also very easy to see on your CBCT scans. The mandibular canal, we already talked about tracing it. Mental foramen, it's already somewhat clear on most of your panoramics, but on a CBCT, there's no question about where you're at. Again, we can trace out the mandibular canal. Most software allows you to do that nowadays. So it's very easy to avoid those kind of complications with this 3D imaging. Now, one thing that panoramics and PAs don't allow you to do is to see the more finer details of your anatomy. So in this case, we had a accessory mental foramen. So a little smaller mental foramen that came off of the main nerve bundle and exited out in that first premolar area. Well, if you don't have a CBCT and you don't realize that you're dealing with an accessory mental foramen, you might just put an implant right into that area. This patient got off pretty lucky because that implant stopped just less than a millimeter away from this accessory nerve. They didn't have any kind of permanent paresthesia. But again, very easy to avoid these kind of complications when you have the whole picture in the first place. Other things like looking at grafts and integration of graft into the adjacent bone is also very simple. You can You can evaluate for any kind of grafts or voids within your grafts. If you're doing any kind of sinus lifts or anything within the sinus, it's much easier to see on CBCT. In this case, a doctor was going in and doing a sinus lift. Obviously, this bone didn't graft in, and it's very clear to see that this bone has not integrated into the surrounding alveolar bone, and there's all kinds of inflammation present within the sinus. This is something that needs to be addressed before the implant goes in, obviously, but this would be very, very difficult, if not impossible, to see on a periapical or panoramic. Then some more complicated complications. In this case, the doctor extracted a tooth, placed some graft into the extraction site, and that graft ended up getting pushed into the mandibular canal space. Now, on a CBCT, you would be able to very clearly see the relationship between that extraction socket and the canal and be able to plan accordingly to avoid any kind of surgical complications. And then you have these cases where you have implants going into the adjacent roots. This is not a good scenario for anyone. Patients coming in to have their dentition restored, they don't want to walk out having more teeth to restore than when they walked in. These are very simple to avoid just with proper surgical planning. And the first step of proper surgical planning is getting a CBCT to give you the information that you need. Now, even if you're not placing implants yourself, if you're restoring any implants, I really highly recommend that you get your own pair of eyes on the implants that have been placed. The reason for that is that you never know if your buddy down the road who's placing these implants for you has done it properly. Maybe they had a bad day, maybe there were complications during the surgery. You just never know what you're going to get back into your own office. And so for the sake of your patient, you really want to address these kind of implant complications before you really finalize these, because your patient's expecting this to last years and years to come, but a year down the road and the implant's already completely failed, that doesn't look good for anyone. And your patients are putting all kinds of trust into your treatment plans, into the treatment itself. And so being able to address any kind of complications before they arise is a huge bonus both to you and your patient. All right, let's get into endodontics a bit. So this is a paper from the American Academy of Endodontists. In here, they make a number of recommendations very similar to the American Academy of Oral Radiologists, where they state that CBCT is the imaging modality of choice for a number of different scenarios. That primarily being for any time a tooth that needs a root canal treatment. If it has the potential for extra canals or complex morphology, you should really get a CBCT image of that tooth. Now, I find it really funny because they go on to list the teeth that have this potential for extra canals and complex morphology, and they literally list out every single tooth except for the anterior maxillary teeth, like every single one. And while it's funny that it's essentially every single tooth in the mouth, once you've started looking at CBCTs for a while, you'll realize that there's really quite a variation in tooth anatomy. The number of two-rooted mandibular anterior teeth that I've seen, three-rooted mandibular molars, 5 canals and premolars, these teeth, they don't read the textbook. They don't know what we're expecting of them. And so to have that information beforehand, to know that this is going to be a complicated case or that you need to go in and address an extra canal or an extra root, knowing that before you get in there to do the procedure itself is a huge benefit. And, it's always nice to know what you're getting into before you start the actual procedure. And then, of course, cases of trauma, it's always good to have a 3D image on that. And obviously, this can affect any of the teeth that are present. But the AAE, this is their recommendations. So in essentially any case where you're doing a root canal treatment, you're more than justified in doing a CBCT scan. Now, these recommendations might not mean much if it didn't actually make a difference in your treatment plan, right? So there was a study that was done, and the AAE, they discuss this study on their website where clinicians were given a patient and a PA, and they were supposed to come up with a treatment plan for a tooth that was on the PA. They were given all the clinical findings. And after coming up with this treatment plan, they were then given the CBCT of that same tooth. After being given the chance to evaluate the CBCT, they were then asked if they would make any changes to their treatment plan. 50% of the doctors said that after viewing the CBCT scan, they would make changes to their recommendations. Their treatment plan changed half of the time after viewing the CBCT. That's huge. That's every other tooth that you're looking at for a root canal treatment. CBCT has some kind of impact on the way that you address that tooth. Now, the big reason for this is that compared to your periapicals, you're seeing 40% more lesions on your CBCT scans. That's a lot of lesions that we're missing. And, just as far as a diagnostic standpoint, like for your patients and for yourself, that's a really big deal to be able to see 40% more lesions, because for you, that means more treatment. For your patient, that means you're getting that patient out of pain significantly faster, because you're not waiting to have to see these lesions grow and grow and grow before they pop up on your PAs. So here's a couple of cases to demonstrate that. Here on the left, we have a panoramic, obviously, patients coming in because they have some pain in the area, right? It's always just pain in the area. So on first glance, it's probably this molar, right? And, if you have a keen eye, you might say that there's something going on in this furcation, right? Maybe there's something going on with this tooth. And you might talk with the patient and discuss treatment plans of like, oh, maybe we retreat this, maybe we extract this and place an implant. But for the patient, they're not seeing anything, right? Like they have no clue what you're talking about, because this shade of gray looks exactly the same as this shade of gray to them. They completely have to 100% trust your clinical judgment that this is the right treatment plan for them. Now compare that to our CBCT scan. So if we pull up a CBCT scan of the same area, it's no longer this shade of gray, it's this whole radiolucent area that's very, very clear on the CBCT scan. Also, here on the in the periapical region of the distal root, as well as here on the maxilla, a patient can see this, right? I can point this out, and a patient's not going to be like, oh, I don't see anything different. They are very clearly able to understand that something's going on here. And so now, instead of just the doctor being able to see and make those clinical decisions, now it's a coordination between the patient and the doctor to understand what's going on and to formulate a treatment plan together. And so the patients can get more involved into treating their oral health, and being able to sell these treatment plans becomes much easier, because the patient, again, doesn't have to just trust the doctor. They can trust their own eyes with what they're seeing on the CBCT. Another case where we have a couple periapicals showing some endodontically treated teeth. Maybe something's going on up here. It's very difficult to tell, but on the CBCT, again, it's clear as day. Periapical radiolucency, and down here on the mandible as well. It becomes much easier to diagnose these things. Again, 40% more lesions on CBCT scans than on periapicals. And when you're going about your day and looking at 1,000 radiographs, you want to be able to catch things just easier in general. Again, for the patients, it's a huge benefit as far as an educational tool, but for the doctors, being able to catch these lesions earlier is a huge help as well. Now let's take a look at a case from the literature. So in this case, a patient came into a dental office and they were worried about this little pimple on their gums that they have just right next to tooth number 7. So, this looks like a sinus tract to us. And so we take a periapical, right? And this periapical, it very clearly shows a periapical radiolucency associated with tooth number 7. And then a smaller lesion associated with tooth number 8. So this is kind of straightforward, it seems, right? We have a sinus tract, we have a periapical radiolucency. And so our next step is to vitality test these teeth, right? So you go through, you test tooth number 7, test tooth number 8, and they end up responding completely normal. So there's no exaggerated response to cold, there's no necrotic symptoms. These teeth are completely fine. And so what are the radiolucencies from? Now, some might jump to cemental osseous dysplasia, jumping to a pathological lesion, but that's not the case here. And because of CBCT, we can really understand what might be going on in this case. So we take a CBCT scan and we take the cross sections of each tooth. So here we're looking at tooth number 7 and tooth number 8. And when we look at the apices of these teeth, we can clearly see bone loss. And that's not unexpected, right? Like that's what we see on the periapical radiograph. So we can see this bone loss at the apex of 7, loss of the buccal cortex, which again, that's where our sinus tract is coming from, so not unexpected. Tooth number 8, same thing, periapical bone loss. But what we also captured in the CBCT was tooth number 5. And if we look at tooth number 5, there's also some periapical bone loss. And tooth number 5, this has actually been root canal treated, or at least partially. So if we look at the buccal root, we can see this radiolucent line. So this is gutta percha or whatever restorative material they used. But this palatal root is completely untreated. It was missed during treatment. So if we pull up the axial view, what we can see is actually this very large area of bone loss extending from tooth number 5 all the way to tooth number 8 and tooth number 7 and wrapping it back around. And so when we combine the clinical findings of tooth number 7 and tooth number 8 being completely vital with the findings from the CBCT, the initial thought was that tooth number 5 had this persistent infection that had spread all the way over. And so what they came up with for a treatment plan was that there was going to be no treatment for tooth number 7, no treatment for tooth number 8, again, because they tested vital. But number 5, they were going to retreat because we knew that it had a missed canal and we could also see some infection that was present. So that plan was executed, and then several months later, a follow-up CBCT scan was taken. And what they found was pretty amazing. So tooth number 7, again, they didn't treat it because it was vital. And if we compare it to the last image, there's only a small area of bone loss that was present. Lots of bone healed in this area, even though there was no treatment done to tooth number 7. Same thing with tooth number 8. That bone loss that was present almost completely healed. And tooth number 5, we can clearly see that it was root canal treated much better this time, and most of that bone loss is gone as well. Going back to the clinical image, that sinus tract is completely gone. So on our 2D image, this did not give us much insight into what was actually going on in this case, right? We did have some bone loss, we had that sinus tract, but really it was very complicated to understand what was going on. And realistically, there's a chance that we would have never figured out that this was the case with just a periapical. In one world, maybe the dentist didn't end up taking a CBCT, and maybe what they ended up doing instead was, maybe they monitored for a while. They monitored this tooth, but this radiolucency continued to enlarge. And so, after several months of enlarging radiolucency, patient demonstrating symptoms, maybe they went in and they root canal treated this tooth. And maybe this radiolucency continued to get bigger, so they root canal treated this tooth. Maybe they ended up extracting both teeth and placing implants because the infection didn't go away. Like, who knows what could have happened without the information from the CBCT. So is CBCT worth it? I mean, obviously in this case, yes, right? Without the information from the CBCT, it it would almost be impossible to understand what exactly was going on in this case. Obviously, this is more of an extreme example, but there's cases out there like this. And without the information from CBCT that you get, uh, it's very difficult to make the right clinical decisions. Now, let's jump into another case really quick. So in this case, again, patient coming in because of pain. It's always pain. So tooth number 31, patients complaining of pain, especially when they release their bite. When you go to vitality test the tooth, there's lingering pain. And then as you probe around the tooth, there's a very deep, narrow, isolated pocket there at the distal. And when we look clinically, there's this nice line running through that distal marginal ridge. And, the diagnosis for this should hopefully be pretty easy, has all the signs of a fracture, right? This is a pretty easy one to get, even without a CBCT. Now, of course, because patients are always complicated, patient comes back like a week and a half to 2 weeks later, complaining of some pain in the area. And so we take a periapical to make sure that we didn't miss any root tips or that nothing else is going on, and everything looks totally fine, right? This extraction site, it's nothing's jumping out at us. Patient has a little bit of pain. Maybe they haven't been taking very good care of that site. So you give them some antibiotics, they leave, you hope that everything resolves on its own. Patient comes back several weeks later, they're still having pain in the area. You take another PA, everything still looks fine, right? Like there's no indication that there's really anything going on, right? It just looks like a edentulous site, maybe a little bit of bone loss here from where you extracted the tooth, but otherwise, like everything looks normal. So now we take a CBCT scan. So this is an axial view of the mandible. We have the roots of the teeth here. So this is tooth number 27, 28, 29, mesial root of 30, distal root of 30, and then the extraction site of tooth number 31. Everything here with the extraction site looks totally fine, right? Everything looks normal. So why would the patient be having all this pain? If we look at this region right here, you'll notice that it looks very different from the lingual surface of the mandible over here. And what's actually going on is this whole area is an area of osteomyelitis. So from this extraction, the patient got osteomyelitis, and that was the source of all this pain. And if we jump back to this 2D image, there's no indication whatsoever that osteomyelitis is present, right? Like again, maybe right here, but you could argue that that was just from the extraction site. But this osteomyelitis extends all the way to tooth number 27. We don't see anything in this region at all that would indicate the presence of osteomyelitis. So now, did we miss this because we're bad doctors? Like, no, not at all. It's just a limitation of our 2D imaging. There's nothing that we could have done with this 2D image that would allow us to see the osteomyelitis. But with our 3D imaging, it's as clear as day once you understand what you're looking for. Let's think about an alternative again where we didn't have a CBCT scan. Maybe you send this patient home with some pain meds or antibiotics again and hope that it resolves. Patient might get upset or kind of give up on coming back to the dental office and deal with the pain for another several weeks. Maybe the patient ends up with a deep space infection because the infection persists and grows. They end up in the emergency room, end up on several weeks of antibiotics, several surgeries to address the infection. This could have been a very big deal for the patient that was very simply solved by the CBCT scan giving us the information that we need. And this is the big story with CBCT versus 2D imaging, is that with 2D imaging, we're limited to the information that we receive. And because of that limited information, we're just missing stuff. Whether it's endodontic lesions, whether it's pathology, whether it's the morphology of the mandible, we just can't see that on 2D imaging. And being able to bring in 3D imaging, being able to bring in CBCT scans to give us all the information that we need to make the proper diagnoses. That is huge and 100% about what CBCT is about. So now let's get into what we're actually looking at on a CBCT scan. Now I know some of you might already be very familiar with CBCT scans, but some of you might be completely brand new to this technology. So I want to make sure that we're all starting on the same foot and that we don't lose anyone as we get more into the complicated cases. So on a CBCT scan, this is traditionally what you're going to see. You're going to see these 4 images. So these images are your axial, your coronal, your sagittal planes, and then normally you'll see some kind of volume rendering or 3D image. Now, each of these planes correspond to the anatomical planes, right? So our axial slice is going to be that axial plane cutting through the patient horizontally. Our coronal plane is going to split the patient into the front and back, and then our sagittal plane is going through the midline of that patient. And let's talk a little bit more about these. So our axial view, this is as if you're standing at the foot of the patient looking up through the mandible. And it's really important that we as dentists grasp this perspective. And the reason why I say that is because as dentists, where are we usually sitting with the patient? We're usually sitting at the top of their head looking down, right? And so this is a little bit backwards than what you might be used to looking at, but you need to look at these scans as if you're sitting at the foot of the patient. The reason for that is because if you're sitting at the head of the patient looking down, your right and your left are going to be mixed. On CBCTs, our right and our left sides of the patient, it's like on a panoramic where they're flipped. And if you don't look from the bottom of the mandible up through the head, you're going to get these flipped. So you're sitting at the foot of the mandible or foot of the patient looking up towards the mandible in your axial views. So if we go through a axial image, what we have here, bottom of the mandible looking up, we have our mandibular roots that we're coming to, and then we'll come up to our maxillary teeth. So maxillary teeth coming into the maxillary alveolar ridge, and then we can start seeing some of the sinus here. So sinus, nasal cavity, and then as we come back down, here we have some of the airway. We have the ramus of the mandible, and again, left side of the patient is on the right side of the image. So all right here, left teeth, right teeth. Our coronal view, this is a little bit easier to understand. So this is as if you're sitting directly in front of the patient and speaking face to face with them. So again, that's going to mean that our right side of the patient is on the left side of the image, and our left side of the patient is on the right side of the image. So as we come back forward through the scan, we can see the right ramus of the mandible, left ramus of the mandible, coming into our left posterior teeth, right posterior teeth, and then our anterior mandibular teeth. Then we'll have our nose right here, nasal cavity in that same area as we come back, anterior maxillary teeth, right maxillary posterior teeth, left maxillary posterior teeth, and our sinuses. So again, you're just looking directly at the patient, and all of this anatomy, it's exactly what we're looking at on a panoramic, just in a different view. So hopefully it shouldn't be too different from what you're seeing on your 2D images in the first place. But if you need a quick refresher course on anatomy, I'm more than happy to send you some resources in order to do so. All right, now our sagittal plane. This is a little bit more familiar to us because it's going to give us more of a traditional bite wing or panoramic view of our posterior teeth. So here we have the ramus coming down into our posterior mandibular and maxillary teeth, our anterior teeth, and then again, posterior teeth right here and right here, a little bit of our sinus here as well. So for those of you who use cephs in your practice, this is a more ceph-like projection as well. So hopefully you're a little bit familiar from that view as well. Now, one trick with the sagittal view is that your left and your right are going to appear very similar. So if you imagine on a panoramic where your right and your left teeth look different, if you're not careful, you might get confused on a CBCT scan, because while there are some differences between the restorations on the teeth, realistically, it's just a toss-up which one of these is left and which one of these is right. So both sides can appear as the same on your CBCT scan. So just be aware that just because we're looking at a sagittal view and it looks like the right side, doesn't always necessarily mean it is the right side. You don't want to be treating tooth number 31 when you're supposed to be treating tooth number 18. But there are a few tricks around that. So the easiest way is going to be these indicator lines. So on most of the CBCT softwares, you're going to see these lines present on all of the different sections. And this just tells you where you're at in the scan. So for example, these green lines, they correspond to our sagittal slice. So our sagittal is in green, we have green lines. And this is saying that your sagittal slice is right at the midline for this patient. And if we look over here, we can clearly see that, yeah, we're pretty much at the midline. So we have our maxillary incisor, and we're cutting through the spine pretty much exactly at the midline. So you'll see these indicator lines, and if you ever get confused about where you're at in the scan, you just look at those. And of course, this helps with your left and your right as well. So if you're looking at the teeth on the sagittal and you get confused, you can always look at this line and you're on the left side. In this case, you're going to be treating the left teeth. Okay, one fun thing that we can do with CBCTs is rotating them. So this is something that is unique to CBCTs. You can't rotate your 2D images at all, at least not in the same way that you can on a CBCT scan. But while it's very simple, it's very powerful as well. And we'll go through a case and show you why. So here we have a small field of view. We're in the left maxilla. We know it's the maxilla because we have our 3 rooted molars. And again, left side. So this is tooth number 11, 12, 13, 14, 15. And we're focusing here on tooth number 12, the buccal root, because our indicator lines are going straight through that. And when we look at the coronal slice and the sagittal slice, we can see that tooth number 12, it's kind of in the slices, right? More so on the coronal slice, but really to closely evaluate this tooth, what we want to do is we want to rotate it so that the scan, all the slices are parallel or perpendicular to our area of interest. So what we'll do is we'll just take this scan and we'll rotate it. And that's a function that you'll find in any of your CBCT software. And we'll rotate it so that both of these roots are going straight through our coronal slice. And when we do that, we can see that now our palatal and our buccal roots are both nicely present within our coronal slice. But we want a little bit more for our sagittal. And so what we can do there is we can rotate our coronal so that our sagittal line is going directly through that root. And now we have everything nicely lined up. So we have our sagittal root, or sorry, our buccal root in our sagittal plane. We can see the root canal going straight through it. We can also now see this area of bone loss very clearly, whereas on that original, you really can't see it at all. And then our coronal, we can also evaluate the whole entire tooth at the same time, maybe scroll a little bit forward and back, just a little bit. And what we would see here is we would see this area of bone loss in the furcation, as well as along that palatal surface. And looking at this, you know, we have our root canal treated tooth, but then we have this little bump here of restoration material. And apparently what happened in the original root canal is a perforation there in the furcation. And so maybe when we were first evaluating this tooth, maybe even with our 2D imaging, you know, we're saying, the root canal probably just failed. Maybe we'll retreat this tooth. But now with our CBCT scan and aligning this scan up properly, you know, most people are going to extract this tooth and place an implant here instead of opting for a retreat in this case. So rotating our scan, it's very simple. It's a little bit funny when you're first getting into CBCT scans, rotating it. But once you get used to it, it's a very powerful tool. And of course, we don't have to rotate and look at every single area, either perpendicular or parallel, but just in these areas of interest that we really want to understand what's going on, rotating your scan, again, a very powerful tool for us. And really, that's it for our volume manipulation. Scrolling through a scan, rotating a scan, that's the very basics of it. And from there, you're kind of just off to the races. And with CBCTs, you're going to start seeing so much more on your images, and it's going to be incredible what you've missed in the past. Now, with all this new information, it might be a little bit intimidating because there's so much to go through. And so I want to talk about how we're actually going to go through a scan and read a scan. And so this is where our interpretation strategies come into play. Now, to introduce us to this concept, I want to talk about the world's best-selling book on search strategies. And I think everyone's familiar with it, or hopefully should be. And that book, that's Where's Waldo, right? So for those of you who aren't familiar with this is a kid's book. It's a book where you're following this well-dressed man, Waldo, through all these different scenarios where he's in all these crowds, and you're supposed to find him, and that's the whole point of the book is to find Waldo. And it's a fun little book. I have 3 kids, and we go through these books all the time. But my kids, they're 3, 5, and 7. They're not very good at this book, and I'll tell you why. So the way that they go through this book is very sporadic. So it's very random. As they go through, they're looking for people with red shirts, with hats, with jeans. They're looking at the left, looking at the right. They're kind of all over the place. And so a lot of times when we are looking for Waldo, they won't find him on the first pass. And so they're going through again, looking at the page, trying to find Waldo, and maybe they're hitting the same spots. Maybe they're missing spots that they missed before. And even on the third pass, a lot of times they don't find Waldo. Now, if you're like myself and you're a Waldo expert, you would know that really the most efficient and effective way to ensure that you find Waldo is through some kind of methodical approach. Now, I personally prefer the spiral method where you're going from one corner and kind of circling in to make sure that you don't miss anything. But having some kind of methodical approach to searching through an image is a way to ensure that you don't miss anything, right? And of course, because this is the day of the internet, right? The age of the internet, and people ruin everything. People have actually gone through and optimized a Waldo search path. And so if you ever want to crush your kids or your grandkids in Where's Waldo, this is the path that you're supposed to take. Now, with our own images, with our panoramics, there's Waldos in them, right? There's pathology that's present. There's significant findings that we need to find. And as we were trained as dentists, we were all taught to have some kind of methodical approach to it, right? Some systematic search to ensure that you're not missing any pertinent information or critical structures, right? Whether that's going from the right to the left or following some kind of pattern throughout the image, we all have some way to evaluate a panoramic. Now, on a CBCT scan, for those of us who are brand new to it, we're not going to have that methodical approach, that routine that we need to evaluate a scan. And that's kind of tricky, right? Because Waldo can realistically be hiding in any one of those sections. And so I want to introduce to you my own CBCT routine to help you guys with your image searches, right? To help you with your CBCT review. And now, while you might think that this is going to be really complicated because we're moving from one image to many images, many sections to go through, it's actually very simple to review a CBCT scan. It doesn't have to be anything complicated or long. It really can be a very quick process, and we're just going to have 3 steps to this. So the first step in our CBCT routine is we're just going to make some corrections to the scan. Then we're going to go through and reconstruct a panoramic from our CBCT scan. and then we're going to go through the sections. And that's it. It'll probably take you 1 minute after you're used to it to go through a regular size scan. And so it can be a very quick process. And again, we're getting so much more information out of this than our 2D images. It's super helpful to have this routine to ensure that you're getting all the information out of these scans that you need. So with our corrections, first off, what I always do is I always look at my image quality. So this here on the left is what I would consider to be a very nice image. We can see the tooth, we can see the structures within it, trace out the canals, the PDL space, the bone around it is very clear. Our area of interest, this huge radiolucency, is very clear. This is a good scan. Now, if you compare that to this other scan, I don't think anyone would disagree with me that this is a bad quality scan, right? The image is very fuzzy. We call that noise, where you have a bunch of staticiness to the image. Makes it really hard to differentiate between where the root is and where the bone is, our bone height, our bone width. Everything becomes just harder to evaluate. And that's not what you want as a CBCT scan. Now, there are ways to help with your image quality, but really where it starts with is having a good CBCT machine, which is where a company like Prexion comes into play. The reason why I like partnering with Prexion is because one, they're really great to work with, very fun, nice, honest sales reps, but also I really like their image quality. I have many offices sending me scans from Prexion machines, and I'm always very happy with the image quality that they have. And so that's the primary reason why I will do these lectures for Prexion, because if I didn't trust in their image quality, I wouldn't want to be promoting their business, because I don't want crappy scans for all my referring offices, because then I had to look at crappy scans all day. So that really doesn't benefit me if I don't have good images to begin with. So image quality, you always just want to make sure that the structures that you're looking for, whether it's an MB2 canal or an implant site, that they're captured, that you can evaluate them clearly. And hopefully this is done just immediately after you take the scan, just to make sure that you don't have to bring the patient in on another day to have them just take a scan, right? Never a fun event for the patient. So the other correction that you're going to make is you're just going to align the scan properly. Now, we talked about rotating our scans a little bit ago, but for this, we want the orientation of the patient to be adjusted properly. Now, on your panoramics, if you don't put the patient in the machine perfectly the way that they're supposed to be, you're going to get some kind of weird artifact or superimpositions, whatever, on them. And on a CBCT, though, thankfully, you can really position the patient in any orientation that you want, and we can just go in and rotate the scan and correct for that. Now, hopefully, you're not having to correct too much. You don't want the patient standing on their heads while you take the scan, but any minor alterations to the patient's position is totally fine, right? So we can just rotate these slices, and it's no big deal after that. And this might seem like a very minor thing, but in a few minutes when we go through some scans, you're going to see how important this step is to evaluating a CBCT scan. So aligning our scan, we're just going to rotate these. We take them one section at a time. So on our axial slice, we're just going to take an imaginary line through our patient's midline, and we're going to rotate that axial slice until the left and the right sides are pretty much equal. It's as simple as that. Now, with our coronal slice, what we'll do is we'll take an imaginary line through the hard palate, and we want that line to be parallel with the floor. So the reason why we use the hard palate is because, one, it's captured in most of our scans, right? If you're taking a maxillary mandibular scan, most of the time you're going to get that hard palate. But also, it generally has like a nice flat shelf to it at some point, and so it makes it easier to imagine that horizontal line. Now, one other trick that you can do with aligning your scans is you can use the anatomy in your other slices to help you line everything up just right. So for instance, this coronal slice is not lined up right. And so what happens is that as you take this axial slice through all this anatomy, your left and your right sides are going to be asymmetric. So for instance, our maxillary sinuses here, this right maxillary sinus versus this left maxillary sinus, they don't look even, right? Here we have the external auditory canal, the ear space. On the left side, we don't have it at all. And what you'll find is as you begin to rotate this and correct this, this orientation, you'll start to see all the anatomy coming in line with each side. And so you have all the anatomy on one side matching to the anatomy on the other side, and it gives you a symmetry within your scan. And that symmetry is hugely important. We'll talk about that in just a second. Sagittal view, we're also going to use the hard palate. Again, very reliable structure, nice and easy, just parallel with the ground, and you're good to go. Okay, so like I was saying just a moment ago, our alignment is going to give us symmetry within our scan. Very, very important. So we have an axial slice here. We're going through the mandible and some of the maxillary teeth. And when we draw a axial slice, or sorry, when we draw a coronal slice through these posterior teeth, what we should be getting again is a symmetry between the left and the right sides. Left and the right mandible look fairly symmetric. Left and the right maxilla look very symmetric. Even these structures up in the cranium, orbits, everything looks fairly symmetric, and that's what we're aiming for. Again, if we don't have our scan aligned very nicely, this is what's going to happen. So now as we try and go through our scan, it's impossible to evaluate for symmetry. And the reason why symmetry is so important is because it really clues us into the presence of pathology. Pathology is rarely symmetrical. The chance that you have pathology on one side and then the same pathology on the other side, very, very, very rare. And even when you do have pathology on both sides, the chance that it's symmetrical in both areas of pathology, like almost a 0% chance that ever happens. So this symmetry really helps us clue into the presence of pathology in these cases. So let's take a case for an example. So what we're going to do here, we're just going to scroll up through the mandible and then back down. Again, we're looking from the bottom of the patient up. And what I just want you to do is just look for asymmetries, right? Big asymmetries. Pathology most of the time when we capture it is fairly large because smaller pathologies, the patient's usually asymmetric where nothing shows up on our 2D images. So on CBCT scans, we're just looking for asymmetries. So in this case, let's take a look at the right mandible. So as we come back down here in a second, we're going to be looking over in this area. And if you see here, we have a radiopacity here that's not present over here. And the nice thing with CBCTs is that you can always pull up a different view. So when we pull up our sagittal view, what we end up having is this very odd radiopacity. And the nice thing about not being a oral radiologist or oral pathologist, you really don't need to know what this is. You just need to refer it out and let someone else take care of it. But I'm sure most of you would like to know what it is. And in this case, this is a compound odontoma. It's a very benign lesion, but very clearly can see the asymmetry between the right mandible and the left mandible. Here's another case. So we have a scan that's not aligned. And as we scroll through it, it's really tough to make out anything, really. Like the mandible, the maxilla, everything looks so asymmetrical. It almost looks like the patient has some kind of growth deficiency or some kind of syndrome. But in reality, it's just because the scan is misaligned. If we align the scan properly, again, we get that symmetry, right? The left and the right sides, everything's mostly symmetrical. And one thing that we do need to look out for, though, is, again, pathology. So if we pull up these two scans and we come back here into the area of the mandibular molars and maxillary molars, We're looking at the left and the right sides. Everything looks relatively symmetric. Left and the right sides in the maxilla, maxillary sinuses. Everything looks pretty symmetrical until we get up here into the area of the orbits. So on the left orbit, there's this very odd circular area that's not present on the right side. And even the orbit itself almost looks kind of squished, right? In this case, this was a cyst that was present within the brain, a arachnoid cyst. This patient was coming in for orthodontic treatment, and they had this large field of view CBCT scan taken, and this was incidentally found on their CBCT scan. Now, thankfully, the patient was able to get in and get the proper treatment that they needed. But the reason why I show you this case is because that symmetry, or in this case, this asymmetry, played a huge part in making this diagnosis. Because without that asymmetry, there was no way we would have known that this lesion was present. So alignment, very important, but very simple. Just making minor adjustments to the scan by rotating your different sections. And that's it for our first step. We want to make sure that we have good image quality. We want to make sure that we align our scans. And that's literally going to take like 5, maybe 10 seconds at most. Like really, it should be a very natural process as soon as you start going through CBCT scans on a regular basis. It'll become very apparent when you've forgotten to align your scans properly. Now we're going to move into our next section. So next, we want to look at our panoramic, and then we want to look at our sections. So the reason why we do this is because when we're evaluating CBCTs, just like when we're evaluating panoramics, we want to take a more broad to focused approach. And the reason for that is because we don't want to miss anything major, right? When I was in dental school and learning how to evaluate panoramics and PAs and bite wings, my professors always told me to look at the teeth last because you don't want to get distracted, right? You don't want to find caries somewhere and totally miss this lesion somewhere else. And that's the same exact thing on our CBCTs. We don't want to get into the specifics right away before we jump into the meat of the CBCT because you don't want to miss that lesion that's present, right? And so by going through and looking at our panoramic first and then going on to the sections, that's going to help us ensure that we're catching everything on the scan that we need to. So our panoramic. On pretty much every CBCT software that I'm aware of, you're able to take your scan and essentially reconstruct a panoramic image from it. So whatever tab or button that you have to press, usually there's some way for you to draw out a focal trough that allows you to reconstruct a panoramic from your CBCT scan. So you don't need your own panoramic separate from your CBCT scan. Some machines will take a CBCT or take a panoramic at the same time as a CBCT scan, but with a CBCT scan like this, that's nice and clear, you can reconstruct a panoramic from that data. And then it's kind of nice because you don't have all the same superimposition and artifacts and ghost images on them that you do in a regular panoramic radiograph. So the reason why we start with a panoramic view, again, is to give us a broad overview. We can see all of the images, or we can see all of the structures within the image. And also, we want to take a look at a panoramic view because we're used to looking at a panoramic, right? Our eyes are trained to pick up on any discrepancies that are present. So by starting with the panoramic, we can just very quickly run over anything that might be present. And again, this can be reconstructed from the CBCT data that you already have, so no need to expose the patient to any further radiation. And that's it. I mean, panoramic doesn't take very long, self-explanatory. Hopefully all of you have been reviewing panoramics on your own and know how to review them. But we're moving on to our last step now, which is our sections. So there is an order that we typically go through our sections, and that's our axial, then our coronal, then our sagittal. The reason why we do this is because first, our axial and our coronal have symmetry present, right? We can see our left and our right sides. Sagittal, we can only look at one side at a time, so we typically leave that for last. Also, it gives us a little bit more of a focused view, especially with our dentition. So we want to start with our broader axial image, then move more into our focused sagittal. Okay, so when I'm looking at a axial image, especially on these larger field of views where we've captured essentially the whole skull, there's a lot of information to go through. And so what I will do is I'll take my section and I'll split it up into 3 different sections. The reason for that is because I can't look at this whole slice at a time while I'm scrolling through, and I'm going to miss stuff if I try to. So as I'm scrolling through a scan, I'll essentially block out those other 2 sections, and I just evaluate one section at a time. So I'll scroll up through this anterior section, and I'm just looking at the left and the right sides, looking for any kind of asymmetries, right? Asymmetries clue us into pathology that's present. And then as I get to the top and have ruled out any kind of pathology, I'll start going back down. And as I start going back down, I move into my other section. So now I'm looking at completely different anatomy, focusing on a completely different area than I did on my way up. And then as I come back down, we're evaluating the airway, the soft tissues within this area. And then when I get to the bottom, I'll flip back to the posterior section and evaluate everything in that area as well. So really on a very large field of view axial scan, I'm just evaluating three different sections at a time and going through from top to bottom one time. So I'm scrolling down through the axial 3 times in total for a very large field of view. On a coronal view, it's very similar, except I like to do it in 4 slices. Depending on your field of view, you can slice this up into 4 or 2 if you have a smaller field of view. But realistically, it's the same process and the same concept. We're just taking each small section at a time to ensure that we can focus on one area so that we don't miss anything in that one specific area. So I like taking the mandible and the maxilla at different times so that I can just focus on the mandible, just focus on the maxilla. Makes it much simpler to go through and evaluate rather than trying to take in everything at the same time. And then for our sagittal view, again, we don't have that left and our right symmetry to compare. So really you're just following one structure at a time and making sure that there's no pathology present. So a lot of times I'll just follow the mandible through, then follow the maxilla through. There's a couple other structures that I'll evaluate, but at this point, we've really looked at everything twice already, right? We've looked at everything in the axial view. We've looked at everything in the coronal view. And now our sagittal, we're really honing in on areas of interest, and in particular, our dentition. So our sagittal view, if we come to our dentition and it looks kind of like this, where we only have like 1.5 teeth present within our slice, what we can do is we can just rotate this, and rotating it, the sagittal slice, so that everything comes through that indicator line. That'll give us a more traditional bite wing or panoramic view. And then you can just simply scroll back and forth just a little bit to evaluate all of your teeth at the same time. Then when you get to the other side, you can rotate it for the other side. And then at that point, we're done, right? We've evaluated the dentition in our sagittal view. If you catch anything there, obviously we can go back in, rotate, look at our axial and our coronal view in those different sections. It's a very simple process. And really, once you've evaluated CBCT scans for a very short amount of time, it's a very simple process and very straightforward. And again, I love CBCTs. I think they're so much better than panoramics or PAs, bite wings, whatever we have nowadays. And I might be a little bit biased, but 100% it's worth it to get into CBCTs, especially at this time. Now, I promised that we would come back to this case, so let's come back. Now, we talked about how we can do a rough treatment plan for this case. Obviously, the mandibular teeth are going to need to be extracted, but I said that there's something that's missing here. So I'm going to give you guys just a few seconds to take a second look and see if you can see what we're missing, right? What is our limitation in 2D that's preventing us from seeing what we need to? So let's go to our axial slice now. We're here in the mandible. And what we want to do, we just want to look at the left and the right sides, right? We're looking for asymmetries, anything that might pop out to us. So we're coming back up through the mandible. Again, we're looking from the bottom of the mandible up straight through. We're just looking for left and right asymmetries. Obviously, we have some periapical infections with these teeth. Now, if you didn't see anything, that's fine, because we're going to go to our coronal view. And again, we're just looking at the left versus the right, looking for anything that might pop out to us, any asymmetries, any indication that there might be something present here more than just apical pathology. And now we're going to skip our sagittal and actually jump over to our 3D volume. So on our 3D volume, hopefully you'll be able to see this very large area of bone loss. And we have our mental foramen there, so we know it's not our mental foramen. But we're going to jump back to our panoramic here and say, okay, well, where's that area of bone loss that's present, right? Like, it's got to be just this right here, right? But when we first initially looked at this panoramic, I highly doubt that anyone caught that. And the reason why I say that is because I've shown this case to hundreds of dentists and no one has caught it before, because everyone looks over here and says, oh, well, there's like a radiolucent area over here, no big deal. And when this case came through and I looked at the panoramic, I didn't catch it myself. But here on the CBCT, we can see it. This area of bone loss here along that buccal surface, loss of this buccal cortex, loss of this trabecular bone. And here on the sagittal view, we can see it a little bit, but not as evident as on the axial and coronal slices. So this is a malignancy. This patient came in for implant treatment. They wanted implants on the bottom and on the top. Took a panoramic to evaluate, took a CBCT afterwards, and without the CBCT, this could have gone untreated for months, possibly. You know, patient could have had pain in this region, complaining of pain. Well, you know, there's a million rotted out teeth there. That's where the pain's coming from, right? So you extract the teeth, pain persists, like, oh, well, maybe it's because they're not healing very well. And maybe you place some implants in, maybe it's because of the implants that the patient is having pain. But realistically, this could have gotten very, very large without our 3D imaging. So I love this case. It shows very clearly the limitations of our 2D imaging. Obviously, pathology isn't going to be present in each one of our scans or in each one of our panoramics, but we are very limited as a profession by 2D imaging. With our 3D imaging, we're able to see so much more, we're able to treat so much more, and our patients just trust us more because we're able to bring them into that treatment plan making. And with CBCT images, you know, it's just a fantastic world that you're going to be getting yourself into. So for those of you who have any questions, here's my email address, also my phone number. This is on my website as well, so radiodontics.com. I also sometimes will post stuff on Instagram, but it's been a while. And then for those of you who want copies of these graphics, they're available on my website as well. So radiodontics.com, they're under the education tab. But otherwise, feel free to reach out to me if you have any other questions. And if you have a CBCT scan that you need evaluated, feel free to check out my website and I'd be more than happy to help out.
Great. This was fascinating. I truly enjoyed it. I'm hoping that we can use this in future lectures that you're going to give us, so we can basically build on this, and we can basically go through this and catch certain things. And as you said, we don't necessarily don't want to know what it is. We can basically just refer, right? You're muted. There we
Yep,
go.
I am muted. Yeah, so like I mentioned before, like your responsibility isn't to diagnose everything. It's just to see stuff, right? There's a lot of questions about liability regarding CBCT scans, like what am I liable for? Well, it's the same thing as with your panoramic, right? You're liable for everything on there. But the nice thing about CBCT scans, again, it's easier to see, right? Like this case we just saw, you're not seeing that malignancy on a panoramic, but your liability increases no more than if you're taking a panoramic on a patient, especially if you're limiting yourself to a field of view that's just capturing what a panoramic would. It's not like all of a sudden you're 3 times as liable because you're capturing the same structures. Like it's the same liability, it's the same responsibility as any other image that you're taking.
Great. I wanted to thank you for joining us today. Hopefully we can have more of these, but this was very nice. Thank you very much.
Of course, my pleasure.
Great.